Okay. All right. And everybody is in. A very good evening to everybody. And we are here talking about psychological counseling and interventions in recurrent implementation failure, which is called RIF. And we have Karen also from Copenhagen with us. We welcome her, and we are going to be talking a lot to her and asking a lot of questions. So when we talk about Karen, Karen is deeply into the psychological counseling and taking care of the patients and doing a lot of podcasts on fertility treatment and the issues which people are facing. So that's Karen, and we move on to the one who is really dear to us, Dr. Poonam Nair. She is the one who has been going up and down, making things happen here in India. And recently she met Karen, and we also have our consensus statement come in. And we have Dr. Anupama with us, our very lovely Dr. Anupama from AIMS Rishikesh. And she's also into the fertility treatment. And she is a very good teacher, I'm told. And she's got a lot of good awards for being a very good teacher at AIMS. And then we are going to be joined with Dr. Divya Shri, who is also a co-convener. And she is also she's the director of the Fertility Center in Bangalore, and she's also the co-convener with Dr. Anupama, and convener B of SIG Group being Dr. Poonam Nair. Moving ahead, we are going to be joined with Dr. Amita Puri, who is also very dear and lovely. And she is very beautiful when it comes to relationship counseling. And she's also taking care of the couples and how the couples are. Dr. Ma'am, you're calling me over.
Okay. Continue.
Okay. I think I'm back. I hope you all can see my screen. So Dr. Amita Puri, we are talking about. She's also into well-being, and she's into relationship counseling and therapies. Moving on to Archika, who is a fertility counselor and a hypnotherapist and a psychotherapist. And we are going to be joined with Sumati also, who is also a lovely and dear person who herself has undergone infertility issues. And, the way she narrates her own story, it is beautiful to listen to her, the way she goes on and tells. And she really talks about the real issues people face. And this is me. I am Ashima Khanna Singh, and I'm just, taking care of the entire process today with everybody. I hope I do my good thing. And then today we are going on. We'll start the entire session by having Dr. Anupama introducing us to what is RIF, what is its definition, and what are the causes of RIF. So let's move on to Dr. Anupama.
Hi. Thank you, Ashima. My voice is echoing.
Yes. Are you logged in from 2 devices?
Yeah.
Yeah. So you have to mute one of them.
Okay.
Yeah.
Can you come on the screen, Dr. Anupma?
Yeah. Would you want to
share?
Can I share my screen, please?
Yes.
Let Anupma come on the screen to talk.
Yeah.
Rahul, give her the screen.
Rahul, give her the rights to Dr. Anupama.
You can share your screen now, ma'am. Anupma, ma'am.
Okay.
Make all the people co-hosts, all the people who are there in speakers have to be co-hosts.
So very good evening to one and all. And it is indeed a privilege to, be on this SIG webinar with people who have such in-depth knowledge of counseling. As clinicians, we don't counsel much. We leave it to the counselors, and our job is mainly to deal with the woman who comes with recurrent implantation failure. And we talk about the clinical management. So to begin with, implantation is the first step in human reproduction. And a successful implantation will take place. It will depend on the crosstalk between the embryo and the endometrium. So embryo is what has been formed in the lab, in the test tube. And endometrium is the soil where it will grow for the next 9 months. But it's very unfortunate that there are some people who cannot achieve a pregnancy. And when it is recurrent implantation failure, it is a clinical phenomena characterized by a lack of implantation after approximately 10% of couples undergoing IVF and embryo transfer. So we know that the success of IVF is not 100%. So imagine with something like 40-50% being the success rate of clinics in IVF, you have another 10% who cannot conceive because of recurrent implantation failure. So it is very distressing and frustrating for both the patient as well as the healthcare provider who are involved in the IVF treatment. And it is a very challenging problem because you actually have to delve into the depth and find out the cause, that why is she having this problem. So there is still no widely accepted definition or a standard protocol for the diagnosis and treatment of RIF. Most couples with RIF, they can become pregnant after clinical intervention. So those in whom stress is one of the factors, well, a good counseling which will help them conceive. So prognosis for the couples with RIF is related to maternal age and several other factors. Now, Ashray in 2012 said that failure to achieve objective evidence of pregnancy after the transfer of 3 high-quality embryos. So it is more than equal to 3 high-quality embryos, or implantation failure with the transfer of more than or equal to 10 embryos in multiple transfers can be defined as RIF. Another one that we saw in reproductive medicine, biomedicine online in 2014, they said that failure of clinical pregnancy after 4 good quality embryo transfers with at least 3 fresh or frozen IVF cycles, and women who are under the age of 40. So the objective evidence of pregnancy is what? It is observing an intrauterine gestational sac detected by an ultrasound. What are the causes of RIF? Now, it can be caused, it has multiple causes, which can be immunological, thrombophilic abnormalities, male factors, embryo aneuploidy. So we need to determine the most possible etiology. We need to individualize the treatment, which is aimed at the primary cause. That is effective method for increasing the implantation rate. And couples with RIF require psychological support and appropriate clinical intervention. So remember that psychological counseling and support forms one of the mainstays of treatment. It's just not finding the cause and treating it. They're already so stressed out after having so many embryo transfers that they need to be morally boosted. So the main known risk factors for RIF, they include BMI, that is more than 30 kilogram per meter square, smoking, alcohol consumption, and stress. Yes, stress plays a very, very important role, and that is why psychological support and counseling is so important. Now, the incidence, because there is no clear-cut definition, and there are variation in definition for recurrent implantation failure and biochemical pregnancy, there is scarce data that accurately represents the incidence or prevalence. RIF, it is a complex clinical phenomena with several different etiologies, which we've already spoken about in the last class. So remember one thing, you can't blame just the woman. So there are maternal factors, there are paternal factors, and there are embryo factors. So we need to counsel and we need to look at these causes as a whole and not just, delve into one of the partners. So there may not be one single cause, but several factors working together, which leads to RIF. So you can have a maternal and paternal factor, you can have a maternal and an embryo factor, or whatever the combination may be. So with this, the embryo and the endometrium, they need to be in synchrony. Identifying the causes of RIF and providing individualized treatment can improve the implantation rate. So the treatment of RIF remains challenging, and counseling the couple, it holds the key. Therefore, I will now hand over to Ashima, and she will take it forward from here. Thank you so much. That was just a brief introduction.
Thank you very much,
Thank you.
Dr. Anupama. That
No,
was
thank you.
you are saying it is a brief one, but I think it gives the overview and the understanding of what is RIF and how it really is important to understand the fact that psychological intervention is a must, because it can be any factor. But in a country like India, more often than not, a woman is made responsible for everything. So, Dr. Poonam, would you want to add a comment, or Dr. Karen, would you want to add a comment before we go on to our role play?
Yeah, I
Yes,
think
thank you for a
this was
nice presentation, and I totally agree that it is a huge mental labor for the couples and for the healthcare providers when we see patients with recurrent implantation failure. So we have a very big task in the clinics to take care of our patients as well as our staff, because it can go on for a long time. So we need to really detect our very vulnerable patients. So yes, a very fine presentation. Thank you.
Thank you so much.
thank
Dr.
you. Yeah.
Poonam, you were saying also?
Yeah, that is where there has to be a complete synchrony between the clinician and the psychologist. We are trying to help the patient understand why this has happened. They are at a loss. They spend time, they spend money, and lot of things have happened at the emotional level. And the clinical healthcare team is at their wits' end because they are also searching for answers. So there is a unsolved problem in terms of not being able to answer all their questions. They want reassurance. At least trust should be there with the couple that this healthcare team has done their 100% best. They have been absolutely sincere and ethical in trying to help me. And, you know, then the whole process of counseling, not a quick fix solution that once the patient is disturbed, we try to console. The integral part of the counselor, right from the beginning, the day the patient steps into the clinic, the patient is optimistic and happy and very hopeful. We know as a team, 40%, tell the patient 40% success rate, he is optimistic. He thinks he is in that 40%. Whereas we have no prediction or very poor prediction. So with that uncertainty, which is the foundation of anxiety, uncertainty, where do we go? So the clinical team has to collaborate with the counselor at each and every step. Otherwise, the end is where we have litigations, where we have violence against the healthcare team, and we have a lot of mistrust and mental health issues.
Dr. Poonam and
So,
Karen,
yes, thank you, Anupama, for giving us an idea.
And very rightly said that psychological intervention from the beginning, the couple moves in. And if we can, and today when we talk about the couple, we are not just talking about the woman, we are talking about both of them together. So here is a little role play which we have prepared on how the couple may be. This is one element. There can be many of them. So hope you see this, and when we'll come back, we'll discuss about it. So I'm playing this. If you all see it, that's okay. If you don't, then we can probably, see. Hopefully you'll be seeing it.
रिया, तुमने पेपर्स रख लिए, डॉक्टर के पास जाना है, वो तुम रेडी हो ना ठीक से?
Yeah, I kept all started okay.
And how are you feeling today otherwise? अरे क्या ठीक हो? बोल क्यों नहीं रही हो कुछ भी?
Feeling का क्या बताऊं यार? I don't know. इतने हार्मोनल इंजेक्शंस, 3 IVF फेलियर्स, एंड तुम्हारी मम्मी, तुम्हारे बहन, they're all after my life, and I mean,
मम्मी बीच में जब डॉक्टर के पास जाना है, ट्रीटमेंट कराना है, बात हो गई थी जब ऑप्शन नहीं है, बच्चा भी चाहिए हमें, तो ये मम्मी का रोल कहाँ से आ गया है? तुम्हारे दिमाग से जाती नहीं है क्या चीजें?
तुम्हारी मम्मी
यही घूमती
ताने देती रहती है मुझको। तुम्हारी बहन जो बड़ के बोलती है, उसको लगता है जैसे मैं कुछ कर ही नहीं रही। डू यू इवन नो हाउ दे टॉक टू मी? कैसे बात करते हैं वो लोग मुझसे?
हाउ? नो, जस्ट एक्सप्लेन मी हाउ। कि मतलब कैसे बात करते हो? वो जो भी बात करते हो, तुम मुझसे कैसे बात कर रही हो? तुम्हें क्या लग रहा है तुम अकेली सफर कर रही हो? और मैं जो इतना ड्रेन आउट हूँ फाइनेंशियली, मैंने बोला तुम्हें कि एक एक साइकिल में कितना हूँ फाइनेंशियली, मेरे को मैं खुश करता हूँ अपने आप को, कितना मेरे को एफर्ट डालने पड़ते हैं, एंड देन फेलियर्स। क्या फीलिंग आती है? मतलब एक मैन की, यू डोंट अंडरस्टैंड अ मैन, यू जस्ट अ वुमन, बिकॉज यू आर टेकिंग ऑल हार्मोनल इंजेक्शंस, एवरीथिंग इज हैपनिंग टू योर बॉडी, all doctors paying attention to you. What about me? मेरा कोई कंट्रीब्यूशन ही नहीं है एक्सेप्ट सिंगल स्पॉट।
Did I say that? ऐसा कुछ भी बोला? मैं तुमको बोल रही हूँ,
बोले।
तुम्हारी मदर और तुम्हारी सिस्टर, तुमने बोल दिया बहुत कुछ, मुझे भी तो बोलने दो यार। तुम्हारी मम्मी, तुम्हारी बहन, आई मीन 3 आईवीएफ फेलियर्स में मेरा मेरा स्ट्रेस लेवल, मेरा तुम्हें मालूम है मेरे साथ क्या हो रहा है? आई नो, यू नो, यू आर आल्सो सफरिंग, बट व्हाट अबाउट मी? कितनी बात तुम्हारे लिए आराम से हो जाती है ना? I understand you want a kid, I want a kid, and my body is undergoing a lot of hormonal treatments. And do you know what it does to me? Nobody's talking to me nicely. Everybody is looking at me as if I'm the culprit. मैंने पता नहीं क्या गलत कर दिया है. I really don't know.
अभी डॉक्टर के पास जाना है, कंसल्ट करना है, तुम रोने बैठ गई हो। अरे मम्मी और बहन दीदी को सबको छोड़ो ना।
कैसे तुम देखो कैसे बात कर रहे हो? Look at the way you are talking to me. You don't understand.
मतलब तुम्हें समझ नहीं आ रहा कि मुझे स्ट्रेस है, मुझे कितना स्ट्रेस है, मैं किसके पास जा रहा हूँ बताने के लिए स्ट्रेस? तुमने तो रो के निकाल दिया अपना स्ट्रेस कि स्ट्रेस है, इसने वो कहा। मुझे भी लोग पूछ रहे होते हैं कि भाई साहब ट्रीटमेंट चल रहा था, क्या हुआ? भाई साहब
IVF failures, they showed us that embryo in the petri dish, and they said we are going to implant this in you, and you know you will have a baby. And all 3 times I felt as if I'm going to become a mother. I know you are also not feeling good, but
आज डॉक्टर के पास जाके प्लीज आगे क्लियर कर लेना कि कब तक चलने वाला है। प्लीज, ये अब मुझसे नहीं हो रहा है, ठीक है? Failure.
Do you know how much I have bloated because of all these treatments? My mental level is gone. तुम्हारा और मेरा relationship is completely suffering. You're trying to tell me your problem. मैं तुम्हें अपनी problem बता रही हूँ, मगर हम consensus पे तो आ नहीं रहे ना। तुम अपनी बात
I'm not satisfied in any way. I'm not happy anyways. ना तो बच्चा मिल रहा है, फाइनेंस भी मेरा ड्रेन आउट हो रहा है, वाइफ को भी मेरी देखो तो वो स्ट्रेस आउट हो रही है। मुझे तो लग रहा है
क्या मैंने भी तो अपना करियर ताक लगा दिया ना। I'm not working for the last 3 years because of all this. Do you even understand that financial freedom I had? I have lost my financial freedom.
No, you can't blame me for that. That was your choice. I didn't stop you, but जो करना है वो तो करना ही है। अब बच्चा हमें चाहिए।
ट्रीटमेंट लेके अपने बॉस के साथ जाके बहस करूं और वहां जाके वो लोग मेरा मजाक उड़ाएं, इससे अच्छा तो तुम्हारी बातें, तुम्हारी मम्मी पापा की बातें, तुम्हारी बहनों की बातें सुन लो। अभी मुझे और कुछ बात नहीं करना है। लेट्स गो टू द डॉक्टर एंड सी व्हाट द डॉक्टर हैज टू से। आई डोंट वांट टू टॉक एनीथिंग।
यू आर गेटिंग एवरीथिंग एंड आई एम डूइंग माय बेस्ट। आज डॉक्टर के पास चल रहे हैं, हम सब कुछ क्लियर करेंगे कि क्या करना है आगे।
क्लियर नहीं होता है तो मैं अपनी जॉब वापस ज्वाइन करूंगी। तुम्हारी मम्मी को बोलो जहां से मिलता बच्चा ले ले। हमारी मम्मी को बोलो कहाँ से बच्चा मिलता है ले ले। Karen, sorry, it was a little more in Hindi. We did not know we'll have the pleasure of your company. Otherwise, we would have planned it a little more in English.
Yeah, it's fine. It's fine.
But hope you got the crux of it. It's basically the couple fighting, and the husband here is pretty straight. You know, he's not hanky-panky, and he's not the one who's really blaming. But there can be all types of husbands and wives. So a quick feedback on this before we move on further. Dr. Poonam, Sumati, you have undergone all this. So when you see a role play like that, what comes to your mind?
Ashima, it
This
was a
very
wonderful
depicts the, the joint family dynamics, which are so prevalent in India, where, okay, the couple themselves is not always a very good team. There's the mother-in-law, sister. They are very important in that in the life roles of the husband. So I think the task becomes even more challenging. The wife may be more isolated, and the psychosocial support has to take into account this aspect of this influence of extended family. It's very important factor. Yeah. And the whole attitude a commodity after paying so much money, you know. So there's a lot of things which need to be aligned from day one. Otherwise, they will end up with this fighting, and we have cases of divorce at the end of the ART process. You know, we have seen cases like that.
The entire quality of life suffers, the couple satisfaction, the relationship, everything
So,
suffers.
yeah. So, can we have the discussion on this? We have framed some questions and to hear everybody's
And would
viewpoint
you want
on
the
this.
audio, the video of Karen to be played before we get into a discussion?
This whole scenario.
Ma'am?
To that. Yeah.
Yeah, I think yes.
Yes.
Karen's video will be good.
Yeah, I
Yeah.
think we'll have to go to that first.
Yeah.
All right.
There's a depicts.
So going on to that,
Our
I'm
main
playing it
video
from
now.
here.
Yeah.
Yeah. Can you all see the screen, please? Is it visible to all?
English
Shall I play?
last eller det.
Yeah.
Ej, hvor sjovt.
I'm playing it. Visible?
Yes, it's visible. But we can't hear.
Yes. Yeah.
Audio is not working properly, Ashima.
The audio is not coming on.
In Copenhagen.
Can you hear it?
Yes.
Now it's here.
I have for the last 14 years worked with primarily recurrent pregnancy loss patients, but also with infertility and RIF patients, and therefore witnessed the psychological impact that infertility has on patients. I have no conflicts of interest. The next 20 minutes, I'll talk about how to understand the psychological impact of recurrent implantation failure, hereafter referred to as RIF. I'll compare the ESRA guidelines for infertility, RIF, and recurrent pregnancy loss, hereafter referred to as RPL. And also, I'll talk about how to increase awareness of the psychological counseling and interventions for patients with RIF. And finally, I'll talk about psychological intervention studies tested on RPL patients. Please note about the status of the RIF psychological research that it's a less defined body of research for RIF than RPL, and much research is on women, and partners must be considered and included as well. It is well documented that there are negative psychosocial consequences of infertility and its treatment on women and their partners. The negative psychosocial consequences are increased depression, anxiety and distress, and decreased psychological well-being, quality of life during fertility treatment, and distress is higher in those with unsuccessful treatment. In an international study by Boivin et al. From 2022 of the impact of infertility on mental health, relationships, and daily activities for approximately 2,000 male and female infertility patients, 60% said that infertility impacted their mental health, and the most common emotion were sadness at the infertility diagnosis and anxiety during treatment.
This indicates the need for support during treatment. The psychological burden of treatment for infertility. 1/3 of patients will end treatment without achieving a pregnancy or live birth, and many experience difficulties adjusting to their unmet parenthood goals. 22% discontinue treatment because they believe they cannot face the burden of another ART cycle, or because they indefinitely postpone the decision to start another cycle. In general, women, childless women who have experienced failure to conceive report the lowest life satisfaction and the highest levels of depression. Treatment burden should be addressed by better care organization and support for patients. Patients should be well informed, have the opportunity to discuss values and worries about treatment, and receive advice to decide about continuing treatment. This insight may help to improve quality of patient care by making care more responsive to the couple's needs. The psychological impact of RIF. We must remember that each failed treatment cycle is a loss for the patients. The psychological impact of multiple treatment failures, multiple losses, gives cumulative grief. The patients have less hope than those starting treatment, and the uncertainty as to whether they will become pregnant in a future treatment is a stressor. Also, waiting period between treatment and pregnancy test can be more stressful than during treatment. This comparative study by Coughlin et al. From 2014 wanted to determine whether women with RIF after IVF, similar to women with RPL, had significantly higher stress level than women without a reproductive failure, and also to compare stress levels between women with RIF and women with RPL. When we look at the numbers here, we see that the women with RIF and RPL had significantly higher stress scores than controls in the fertility problem inventory. Control group were women without a reproductive failure and shows in the gray pillar. A finding that is not surprising for RIF patients, given that these women had consistently failed to achieve a clinical pregnancy despite repeated IVF treatments. The perceived stress scale score was significantly higher in the RPL group than controls. The score of the RIF group was not significant, although the difference tended towards statistical significance. The psychological impact of RIF is a vicious cycle due to treatment burden and dropout and multiple reproductive failures. RIF is also associated with discontinuation with treatment. Partners also experience burden. Partners feel a social isolation and feel a sensitivity to comments from friends and family. And the non-event is a traumatic experience. So there is enough evidence that patients experience subclinical and clinical psychosocial problems during treatment to warrant that these needs must be addressed, even if they do not impact on the treatment outcome. Patients themselves express a desire to see these needs addressed. So how do we address these problems? The ESRA guideline for psychosocial care in infertility, RIF, and RPL highlights the importance of psychosocial care performed by the fertility staff and addressing common needs of most patients. The current guideline for infertility and ART from 2015 was initiated by members of the 1999 Guideline Development Group, supplemented with advice from additional experts in the field. However, whereas the previous guideline was developed to assist mental health professionals in providing counseling and psychotherapy to infertile patients, the present one, although from 2015, focuses on guiding all fertility clinic staff in the provision of routine psychosocial care. For instance, the present guideline only includes psychosocial interventions that can be delivered without the presence of a mental health professional and do not require specialized training. Until very recently, psychosocial care was mainly considered to be the responsibility of mental health professionals. All relevant ESRA guidelines recommend supportive care, screening, and provision of information, treatment planning, and preparation for multiple cycles as part of treatment to be administered by the healthcare professionals. And if psychological intervention is needed, then referral to a therapist. Until there's more insight and data on the mental impact of RIF and unsupportive treatment options, ESRA good practice recommendations on RIF refer to the ESRA RPL guidelines for supportive care for patients. Both guidelines consider psychosocial care as an essential part of fertility treatment and should be provided before, during, and after our treatments. Couples' psychological states and needs will vary, so there's no one-size-fits-all model for supportive care for couples with RIF and RPL. But based on guidance on RPL, the following approaches can be applied. Recognize the woman as an individual, this woman, her story, her pregnancy. Be present and mindful. Provide time for questions, information, repetition, and discussion. Listen to the facts and feelings of the couple. Show respect for the patient, the couples, and their wishes and choices. Use clear and sensitive language, explain terminology, avoid insensitive terms, and mirror the patient's preferred terms. Be honest about processes, likely outcomes, and prognosis, and avoid false reassurance. Applied shared treatment planning in a partnership approach. This enables a patient to have some element of control. Be kind, show concern, empathy, and compassion. And here are some examples of which aspect and components that are important to fertility patients and that can be provided by the fertility staff. The fertility staff should be aware that patients value how the staff relate to them, being involved in decision-making, also that both partners are involved in the treatment process, and staff showing understanding and paying attention to the emotional impact of infertility. Also, the provision of opportunities for contact with other patients is a thing that the patients value, and receiving psychosocial care from sensitive and trustworthy staff members, and receiving attention to their distinct needs related to their medical history. The couples also want to sit down and have time with the doctor and the nurse. Also, patients value small things like minimal waiting time, not being hurried in medical consultations, and continuity of care. In our clinic in Denmark, we provide psychosocial care for our patients like the examples above. And we always try to make an effort to involve both partners in a personal approach. For instance, we call in the couples by both their names, we minimize waiting period before controls, and we recognize their medical history, and we give personalized care. We are open for discussing new approaches, and the patients are involved in decision making, but we're also very realistic about the possibilities for outcome. Also, sometimes we see the couples for many years. We also provide opportunities for contact with other couples through meetings we set up in a small group of couples. This gives them a chance to talk with peers, and we have continuity of care. We try to be the same staff every time. So psychosocial care also includes screening as a tool to detect the vulnerable patient. Because some patients are more vulnerable to the burden of treatment and need additional psychosocial support, especially in case of multiple cycles. Identify those at risk before starting treatment. ESRA recommends screen IVF and fertility out of 12 screening tools in the guideline for infertility. These screening tools are fertility specific. So here we see the two screening tools that ESRA recommend, the Screen IVF and the vertical questionnaires. The information that patients provide us by filling in one of these questionnaires will help the fertility staff to determine the possible emotional impact of the fertility treatment. The fertility staff are then able to advise patients as to whether they could benefit from additional support from a counselor, psychologist, or social worker. Information provision and treatment planning. Forewarn patients about possible need for multiple cycles, prepare patients for impact of treatment. And why is this important? Well, it increases the patient's resiliency and coping in order to decrease the dropout due to the psychological burden of the treatment. Plan for multiple treatments rather than cycle-by-cycle approach. Prepare for unsuccessful fertility treatment as a routine. Explore possible outcomes, chances of success. Include both partners. So, psychological interventions for infertility. The market is full of psychological interventions for infertile couples. I'll talk about two of these interventions: meditation and mindfulness, and positive reappraisal coping intervention, that are both tested in RPL patients, but not yet in RIF patients. Those are the ones marked in red on the slide. So the first one, meditation and mindfulness, has been tested on women with RPL in a randomized controlled trial. The study question was if participating in a tailored 7-week meditation and mindfulness program with additional standard supportive care versus standard supportive care only could reduce perceived stress for women with RPL. This study documents that a 7-week daily at-home meditation and mindfulness program combined with group sessions and with additional standard supportive care reduced perceived stress significantly more than a standard supportive care program for women with RPL after intervention completion. So when we look at the numbers, we see that at baseline, the intervention and control group, there were no difference. They both scored 20 points at the perceived stress scale. And 7 weeks later, there's a significant difference between the intervention group and the control group with a p-value of 0.027. In the intervention group, stress levels decreased with the mean value of 5 points from baseline to 7 weeks after. And in the control group, stress levels decreased with a mean value of 2 points. Both decreases were significant. Both groups received our specialized tender love and care support. Stress remained low 12 months after baseline in both groups, but not significant comparing the groups at 12 months after baseline. The result 12 months after baseline showed that a support care program in this study, nurse-led, is stress reducing itself and also is part of a psychosocial care. The psychosocial care that I was talking about on the other slides. Sorry. So how did the patients react to this intervention? The intervention group were given the opportunity to provide comments about their perspectives on the impact of the meditation. And I'll now read a quote from one of the participants. She says, "I have felt that I've been able to do more things more easily and have had the energy to be with other people more than I normally can. I'm also sure that it has something to do with the fact that I sleep better after I have started meditating every evening. Normally I sleep poorly and the nights are filled with nightmares. Those are completely gone now. We have been more together with our friends with kids without me being drained and sad when I leave them." But also one patient felt it as a provocation that we talked about meditation and mindfulness now when they were in such a struggling time of their life, as if it could solve their fertility problem. She wouldn't participate in the intervention, So it's very important to know when and how to approach the patient with any intervention. So the next intervention I'll talk about is called positive reappraisal coping intervention. And it's a self-administered intervention originally tested in fertility patients in the 2-week waiting period before testing for pregnancy. This study showed that the women had significantly higher anxiety than in the treatment period. Later, it was tested in RPL patients, and one could consider to apply it to RIF patients. So the positive reappraisal coping intervention is an active strategy which aims to reduce the emotional despair of a stressful period by focusing on the positive aspect of a situation. It's called Pre-CPRCI, and it's a small card containing 10 positive reappraisal statements that aims to encourage users to redefine the waiting period more positively. Users should read the card at least twice a day to stimulate the use of this form of coping. And I'll just read the 10 statements that should be done twice a day. So the patient should ask themselves, try to do something that makes me feel good, see things positively, look at the bright side of things, make the best of the situation, focus on what is important in life, focus on the positive aspect of the situation, find something good in what is happening, try to do something meaningful, focus on the benefits and not just the difficulties, and learn from the experience. So these are the statements that the patients are advised to do twice a day. So at the end of this slideshow, I'll just come with the take-home points on psychosocial care for RIF patients. So RIF is a vicious cycle of treatment burden and dropout and multiple reproductive failures. So we must prepare patients for realistic outcome before starting the fertility treatment. The ESHRA guideline for psychosocial care in infertility and RIF highlights the importance of psychosocial care performed by all fertility staff. Routine psychosocial care is considered an essential part of fertility treatment and should be provided before, during, and after treatment by all the fertility staff. Also tell patients that treatment may require many cycles, help prepare and build resilience for coping with multiple cycles rather than cycle-by-cycle approach. And also meditation is a useful tool for patients with reproductive challenges. Thank you all for your attention, and I wish you a very nice Congress. Goodbye from Copenhagen.
I think that itself summarizes a lot, the entire talk of 20 minutes. All the people who have been listening, hope they got a big insight. And Karen really did mention every aspect of psychosocial care in RIF, which she was talking of. So shall we hear a little more if she has something to add to whatever is there already? Karen, yeah.
Thank you. No, actually, the only thing that I want to add is again to emphasize the importance of the psychosocial care, because like I saw in your role play, even though I missed maybe 50% of it because it was not in English, I do understand body language, and I see the
You're losing Karen, is it? There's a network glitch. Ma'am, can you hear me?
Karen gone offline.
Yeah, I think there is some network issue.
Yeah.
Your voice is very low.
Yeah.
Whose voice?
Your voice is very low.
My voice?
Now it's better.
Who's?
Okay.
Yeah.
Ashima's voice is a little low.
Can you hear me?
I think we can.
Yeah,
I think
Karen,
we can start till Karen is. Hello, Karen. We lost you for some time. We lost the connection. Mhm.
Yes, I know we lost the connection. It's fine. I'm here again. So yes, but what I was saying is just that
Role
it
playing
just
with us.
emphasizes that we need to take care of the patients from they enter the clinic, from before treatment, and make a take a good talk with them about the expectations, so they know that it might not work first time, or maybe not even second or third time, and tell them that we are ready to take care of them as much as we can. And if they are more challenged, that the healthcare staff can provide from psychosocial care, we must refer them to a counselor. So no, I have no further comments that this. Let's hear if there are other questions. Yes.
Yeah.
Sorry, I think I've gone on to playing it again. Yeah, Poonam ma'am, do you have any questions, or anybody who want to ask questions, or shall we?
No, I think what Karen has said is basically there's no quick fix solution. The care has to start right from day one. We don't wait for the patient to get into the deep wood and then try to rescue them. Like a lot of ART centers say that we have somebody in the HR who's doing the counseling. How do they do the counseling? I don't know, because when they find the situation getting out of the, which is a very incomplete way to provide psychosocial care. That is what the guideline, the legal mandate is, that the counselor should be there full time, tracking each and every patient from beginning to end. So I think that centers need to get into on a much bigger way. Otherwise, it has repercussions, like Dr. Karen said, that not only the patient is uh, at a loose end or in a bad way, but that it's very bad for the healthcare team morale also, isn't it? So let's look at the panel questions. What are the psychological?
Yeah.
The panel discussion is open for everyone. I mean,
Yeah.
everybody can give their points of view. So we can start with this very basic foundation question. What are the psychological challenges?
Yeah, what are the psychological challenges faced by the
Archika,
couple in
Good evening,
recurrent
ma'am. I'm here.
implantation? A lot of Archika.
good
Am I
evening.
audible?
Yeah.
Come on the screen, please.
Ma'am,
Yeah.
I'm on my this thing.
Yeah, we can see her. She's a little too far. Yeah.
No,
Yeah, now it's fine.
Yeah.
no,
We
we
can
we
see
are
her.
just seeing your question, not Archika.
Okay, okay. I'll just put the
Am
question,
I
then you'll see her.
Yeah.
okay? Hello, ma'am. Thank you. Thank you so much.
Mm.
So, infertility is not a disease, ma'am, and definitely, but its treatment can affect all aspect of people's life, which cause various psychological challenges and issue. And as in Dr. Karen's talk was there, she very nicely explained everything, and Dr. Anupma was emphasis. The stress is definitely a biggest enemy in this, and the very first thing comes. And in a role play, we were trying to portray what the state of mind of husband is. He was so frustration was there, anxiety was there, and the kind of hopelessness where they were losing all kind of hope. Then sadness definitely, and sometimes to some point we feel we are worthless. And when we combine all these components and we do that analysis, we feel like the quality of life is definitely going to decrease. So all these factors, all these are psychological challenges. And as you were explaining, Dr. Karen and Anupam, I'm explaining that it's very, very important that we should start the psychosocial, the treatment before this. This care is very much needed. It's kind of rule. We cannot and we should not even attend it. Later on it can develop various kind of infection. And this infection is context in a anxiety feels so heightened, if the sadness is heightened, and depression definitely. So all these are the psychosocial challenges we face and we are facing, which we need to go further
Yeah.
with our interventions and all.
Absolutely. Absolutely.
And I think here the unique feature of our culture is the high involvement of the family. I think that does create extra challenge for the couple. I
And
think
that's
that
extra
is something.
force we feel, we feel like it's an extra burden on us because we are unable to
Yeah,
sometimes deal with that pressure.
yeah. So a
Yes.
husband-wife relation, and then there is the entire relationship with the extended family and their
Yeah.
in-laws.
Exactly.
Yeah.
Exactly.
And I have a comment also on the family dynamics you have in India. They are more there's much more on stake in India than I guess in Europe, because as you said that it's the women's fault. I mean it's not, but it's often considered like that. And I think it's more accepted in Europe that it's equal male and female factor.
Yeah.
Since 40% of the patients, infertility patient has male factor. So I think in Europe
we
we
have the
are,
same thing for the speaker because we are just seeing the question. Can we remove the question, Ashima?
Yeah.
Please. This is okay. Thanks.
should I continue?
Yeah, please,
Yeah.
ma'am.
Go ahead.
Okay, yes. So I actually had an Indian patient. She lived in Copenhagen,
Yes. Yeah.
and she said that she could not go back to
Dr.
India without
Karen,
a
is
child.
that
Can you
Dr.
hear
Karen
me?
is talking about an Indian patient, Dr. Poonam.
Yes, that what I was saying about my Indian patient, that her mother-in-law could not understand that she suffered from RPL, because she could not understand that we could not treat her in Denmark. We were must be idiots, because how
sorry?
can we make her pregnant? And even in India, she also tried fertility clinics, and it didn't succeed for more than 5 years. And now I don't know what happened to her, but talking about this with you Indians, I come to think of her again. And with the role play, which I think was so interesting, because there's as I said before, it's more accepted in Europe that it's also can be a male factor. And I think what I hear from you in India and what I've read, that it is the woman's it's her fault, even though
That's
it's not her
Very,
fault.
very well said, Dr. Karen. And in a role play also, we will try to portray the male was emphasizing that I am doing everything and I'm financially drained out. What else I can do? What else?
Exactly. Yes. What do you want
That
to
is
do?
on my
I
part.
cannot do anything more. I go to all the specialists and I'm getting pregnant and I'm losing the pregnancy. I retry. I'm losing. I think she lost 18 pregnancies.
Oh,
And
that's too much.
yeah, and the mental labor with her, I was her, more or less, I was with that couple for years and years. And they were so nice and so mature and so understanding. And she just was so much in fear for going back to India to her mom-in-law, because they could
Yeah,
not understand how we could not
Can
fix her.
understand. The family
yeah, but
system here is it's pretty well knit, and yes, the parents are definitely making a lot of decisions. In India, for a very long time, having a son or a daughter was supposed to be something which was in the hands of a woman. So men tended, they had more marriages just to have a son. So that's a story of past now. Ma'am, you're saying something, Dr. Poonam, you're saying something?
Can we move on to the next question?
Yes, let's
Yeah.
go to the next question. Quickly moving on there. And the question number 2 is, how can fertility care team provide client-centered care? And that comes to me, before I go on, I would want to have Karen, because Karen had a lot to say. You had a lot of words, empathy, mirroring. So I think when we talk about client-centered care, empathy is something which is very important as a word. Because if I go somewhere, if I'm not treated well for wherever I am, whether I'm in a hospital, in a fertility care clinic, as a person, as an individual, how I would want to be treated as is how we have to treat our clients or our patients, so to say, who come to us in the fertility care clinic. And the care team, they're all human beings. Here, I'd like to mention one small aspect, that fertility care team never does anything intentionally. It's just that they are also so hard pressed for their time, that they sometimes don't know the way they have to go, because they as human beings also have a lot up their sleeve, a lot of things. But I think that's where the sensitizing of them, understand, being a little more soft, just giving a pat on the hand, giving a little smile, a reassurance. And also, as Karen had a lot to mention about, giving them the entire treatment plan, assessing them right and screening them in the beginning, telling them the pros and the cons right from the beginning, preparing them from the beginning as a couple, is where the fertility care team comes in. Karen, would you want to add something more to it before Dr. Poonam comes in?
Not much, but I totally agree with you. It can be anything from an acknowledgement when they enter the clinic, like good morning, good afternoon. It could be from a secretary, just so that the healthcare staff notice and acknowledge that we have this couple. They are now entering our clinic. So acknowledgement is very important. And as you said, a smile, a pat on the shoulder, and we'll be 5 minutes late and we'll take you in. Just give a heads up notification if we are running late, and be prepared, know their names, know their history, medical history. Don't sit and fumble like, what was it now? Did you have another loss? Or, like that, because it makes you insecure as a patient. We want them to, those are the most important people in our lives. When you have this situation, it's an existential crisis, because getting a family is so high valued, both in Europe and in India. We want to make a family. So there's so much on stake. So if the person we're sitting in front of says my husband's name wrongly, or another name, or didn't remember that I don't ovulate, that my cycle is like this, or another thing, it makes me unsecure. Are they good enough for me? Should I change clinic? Why don't they remember what I said last time? Stuff like that. So it's very small signals. But also, if we turn it around, if we pick up all these signals, we get a very secure patient. So
Very
they
well
will,
said.
and once we have their confidentiality, once they trust in us, we can do so much. We can make errors, because we're only human beings. It's okay to make an error if they know that we are, if we are good enough, if we provide the kindness of concern and empathy and all the words I had. If we provide that, then of course it's okay to be late and not announcing it. Everything's okay once you have a good dialogue. So it's so important with the first step, they come into the clinic, embrace the patients, let them know you're onto this, you've done it before, you know what's going to happen, and tell them that sometimes we are running late. It's just like, and sometimes I cannot come out and announce that we're late, but just know that I can see you on the screen. I know you're coming. We're waiting for you. Small stuff like that. And then, of course, the best medical fertility treatment and all that, the lab work and everything. But now we're talking psychosocial care. So it's more to really build up a relationship. And let's hope we don't see these patients for very long, because we want them to succeed in the first treatment, of course. But as we're talking RIF today, we know that it's recurrent, so they come back. And if in order to get them to come back, they need to have our faith, and vice versa, because otherwise they will drop out.
Absolutely.
And then they have to rebuild another relationship in a new clinic, which is exhausting, which will do that they maybe forget the whole project. So,
Absolutely.
yeah.
Being human is enough if we can show that compassion and build trust.
Exactly. Yeah. Well said. Being human
Bonding
is enough.
is very, very important, and we should know how to rectify our error. Making error is not a, mistake, but we should know how to rectify.
Exactly.
Timely.
Sure.
Yeah.
Moving on to the third
Okay.
question, we call in Dr.
Thank you. Can you have question?
We have not heard from Dr. Amita Puri yet, so let's hear from her. Is it possible to identify couples who are at high risk for psychological distress or breakdown early? That's a very important question, because if we, as Karen was also mentioning, Dr. Amita is right there. So let's hear from her.
Yeah,
Yes,
Shima,
so-
thank you. And good evening, all. So this is a very important aspect that can be identified. Many times we as psychologists, people expect us to do magic. It's just because we are psychologists, they expect, can you do magic? Can you give me a baby? Can you do this? Can you rectify or correct my relationship issues just by magic, by, wand? It's like you have some magic wand in your hands. But yes, we have those magic wands. Those tools are there. The screening instruments are there. And we have the standardized tools are there in the Indian context, like we have PJ Health Questionnaire N2, well-being scale, then sentence completion test for married couples. So many times, like you people, you and Archika did, Ashima did this role play. So one variable came out. There are multiple variables, and many times people do not want to disclose or share. So those are the times when we pick up those non-verbal cues from the patients as they are talking to each other, as they're sitting, as they are looking at each other, their tone of voice, their gestures, their postures, all of those are quite a bit giveaway about what is happening, the relationship dynamics. And there are these simple, very simple tools which we have, as which I mentioned, PGI HQN2, PJW Wellbeing Scale, and SCTM, developed with Indian norms on Indian standardized on Indian population. Sturdy psychometric properties these tools have. And yes, those invisible, or those non-verbal cues which we look at during clinical judgment, and when we give these tools, many aspects, many dimensions, many variables of relationship dynamics do come out, and we are able to summarize with some confidence level that yes, this couple is more vulnerable to psychological distress than the other. And that is where we are able to then design our therapeutic interventions accordingly.
Yeah, thank you very much. That's absolutely rightly put in. Like we have Ferticol and Screen IVF, which is being used by Ashray. As Karen was mentioning, we do have Indian tools which we can use, and we can, right in the beginning, we can understand if this couple is really going on to hold on to things, or there will be a breakdown, so that we can give them the special care.
Ashima, I want to add one point when Mita ma'am very well explained our role play, and I just want to appreciate and acknowledge that exactly when ma'am said the verbal, non-verbal thing. So when I was playing a role of a husband, I was touching my forehead like this. So I was actually wanted to say that I'm fed up with all this, but I just couldn't, and I did. So it was like, ma'am, the sir very nicely explained that sometimes we have to actually non-verbal things we have to catch.
Bringing in a humor element, that we keep looking at the man,
Can
also
we
we
go on
forget
to the
the
next
woman.
question,
What are the cues
Ashima?
she is giving? Yeah, let's go on to the next question, ma'am.
Yeah, we have a lot of things to cover.
Yes, the
And
next question we are putting it to Dr. Divyashree and if Dr. Divyashree is there, otherwise Dr. Anupama can take the question. How can we provide the correct information regarding their medical condition and outcomes, as this information is very important aspect of psychosocial care? Dr. Divyashree is there, ma'am, or Dr. Anupama?
Yeah, I'm here. I'm Dr. Divyash this side.
Please.
Okay, so Ashima, can I go first?
Yeah, I mean, yeah.
So, all these infertile or subfertile couples, as we call them, if the wish of having a baby is not fulfilled, the problem becomes very apparent, and they have, they have low self-esteem, there's hopelessness, low self-confidence, and they start feeling very guilty. So there may be desperation and grief at the same time, and it becomes a problem with the relationship of the partners. So as clinicians, we deal with the clinical bit, with the medical aspect of it, but one has to focus even with the psychosocial and the emotional needs. So we have to actually care for the emotional needs of the couple, and this demands continuity. It is not just a one-off that they have a single event of a counseling session. So the information that we give them and the counseling that we do for the couple, it is, not just the husband or the partner, but both of them together.
True.
When we counsel them, so we have to take into account what the cause of the recurrent implantation failure was, and how we can, like, correct that cause. So as Karen had rightly pointed out, even meditation and relieving stress, it helps. So it's actually a teamwork. It is not only the clinician, not only the nursing staff, but even the embryologists, the counselors, and the psychosocial support that needs to be provided by the family. So everything has to come together. So the individual process and the interpersonal dynamics within the different groups in the team. So the team has to work cohesively and counsel this couple. The clinician has to take part of the cause of the infertility, the recurrent implantation failure, and come to a conclusion that how they can, correct the cause. So even the embryologist may help with what kind of embryos was they provided, etc. So the diagnostic procedures and medical treatment in infertility, they have an important impact on the life of the patient, but the couple's relationship dynamics, their ability to cope with the situation, with the psychological and the emotional effect caused by this entire process, everything has to be taken together, and the future treatment options, they have to be made available. I think
Absolutely. I think what you're saying is we'll have to involve anybody and everybody and have a partnership. Let's move on to Dr. Divya Shri and hear from her quickly. I think because we're running short on time and we'll
Yes.
have to wind up with one more question. Yeah.
Giving the correct information to the couple matters a lot, because many times as doctors we ourselves will not understand why the implantation failure happened. Is it an implantation failure or IVF failure is something that we have to tell the couple, because many a times when they at least understand why the failure is happening, when we know the cause, that is IVF failure, whether it is problem with the egg, it is problem with the sperm, or it is with the embryo formation and the cleavage, or it is with the any other risk factors, like she's very obese or she's PCO, endometriosis. All the factors have to be considered when we are counseling the patient, and we have to give them the information that the failure is happening because of this, if it is an IVF failure. But if it is implantation failure where we don't identify any cause, then the team approach definitely helps, where we have to have the reproductive medicine specialist, the embryologist, then the endocrinologist, the geneticist, also a immunologist can sit together along with the counselor, take the couple into confidence and then counsel them. That will actually give them a lot of confidence, is what I feel. So always team approach is something which we have to do, and also counsel them if there are any causes. And especially if it is obesity, we always underestimate and then probably give them some time to lose weight, and it can have impact on the subsequent outcomes.
Absolutely. Everything matters, everybody matters, and it is a team effort. So quickly moving on to fifth question, let's bring in Sumati in here. Sumati, if you would want to answer, what special psychological intervention can be given by the counselor? Now, when we talk about psychology, yeah, go on.
Thank you, Ashima, for that question. I can resonate with each and every act of yours and Achika's. The words were so meaningful, and it was point to point what I had gone through, because being a counselor now and an IVF patient myself. So I think the counseling should start from the very beginning, where the couple's bonding and their emotional resilience has to be worked on. So that really helps along on going through the process. As I always say, it's not like any other treatment, it's a creation of life. So that point has to be kept in mind by the clinicians. And also, one thing which I would like to, bring in here is the counseling has to be a little, we can bring in a lot of emotion, lot of empathy, and lot of humor also. For example, when the couple goes in for a treatment, it's like a, cricket match. The entire team is there, the manager is there, the umpire is there, but it's the couple who goes down to the ground and plays. So what comes in, you never know. So they have to be kept in a good humor and positive mindset. So I think that should be the psychosocial care which has to be taken care of.
Absolutely. Thank you very much, Sumati. I think with that, we have come to the end, and I think we are all in consensus.
Would like to say something, Dr. Meeta. She's an expert in counseling. She there? Hello? Okay, fair enough. Okay, we can go on. She's doesn't seem to be here. Mhm.
Yeah. So, Dr. Karen, you have something to say before Dr. Poonam Nair concludes it, and Dr. Anupama Bahadur. I think I see Dr. Amita. Um, um, can you see her?
No, I don't have actually something to add that otherwise that it's been so interesting to participate in this workshop because I learn every time from how the Indians are more challenged maybe than the Europeans, and you have other habits than we do. So it's so interesting and learning for me. But we are both on the same side regarding the psychosocial care and the importance of the psychosocial care and how fragile the patients are. And if we don't take care of the patient, they will drop out, and we will not be able to help them. And so it's been very interesting, and I am happy that I could participate in this workshop. Thank you very much.
Thank you very much. I think it is going to be a psychological loss for the healthcare workers who put in their best also if a client goes away and are not
Exactly. Yes.
unhappy. Yeah.
Unhappy. Yes, it's a failure. Yeah. Yeah.
Okay, let's, I think we have come to the end. Let's have Dr. Poonam concluding, and we'll have Dr. Anupama Bahadur coming in for the vote of thanks. So, ma'am, giving it to you.
Okay. It was very interesting presentation, and I think all the points were well covered. The only thing that is of concern is that when we work with the couple, then keeping in view the fact that their relationship in the end is going to be vital in buffering the train. Like Sumati said, they are the players in the field. So one way to do it is that right from the beginning, right from the diagnostic procedures to why we are having this investigations, to why we are adopting one line of treatment, when one line fails, why. So in that entire discussion process, the husband needs to be encouraged to talk. Most of the time, men are problem focused. They said, okay, I had to take her to the doctor, and here it is. What more can I do? So they tend to be not very verbal and not very willing to talk to anyone except the clinician. So here we have a role that right from the beginning, we have to encourage the man to talk to us as well as to the partner about what is happening, how they are planning to go to the next stage. And we hope that in this journey together, instead of their relationship breaking up, we have cases where the relationship actually becomes stronger because they have tried to face a challenge together in a healthy manner. And another thing is about the provision of information, which is a very vital step, like Dr. Divyashri and Anupma said. But the thing to remember is that this is a huge amount of medical information we are giving to bio at all. So it is very important to get the feedback about how much they are actually understanding and given continuously in small doses so that they understand every step and the logic of it. Give them a chance to ask questions. We can check if they have really understood, or a lot of times out of sheer respect which they have for the clinician, they are just quiet and they said, okay. But then they go outside the clinic and start asking admin staff, nurses randomly. And that creates a incomplete info. So I think this is important that we have this huge amount of medical information. We have so much data. It is still ongoing research. We do not expect the patient to be aligned with those breaking pathways. new frontiers and so on. But they should be convinced that we are sincere and we are doing our 100% to help them in every way. So I think empathy during communication when they are very upset, and no matter how much prepared they are, when the shock comes, it is still a shock. So that moment, that special psychosocial care, handling the grief reaction, allowing them to process, giving them time to think of various options, continue for how long, and so on. So I think the main thing is to be with the patient from beginning right till the end. And remember, it's a maybe 4 to 6 years of journey. And so that really is important. Thank you very much.
Thank you very much. Before we go on to Dr. Anupama, if everybody can just show us their videos, if we can have a good photograph and, so that everybody can be
Yeah.
seen. All the other people who have joined, I think there are certain questions. Archika, would you want to read the question? Somebody's writing somebody down. So if all of you can show us your videos and if we can take a group photo, it will be lovely. All of
No, we have actually appreciation. Thank you so much.
all right. So
We win when the team wins. Exactly, Amita ma'am.
all right, all of you, all more. It will be lovely if all of you can unmute. It is a moment. And Dr. Anupama, I'll just give it to you. And everybody's please just show us your video so that I can take a good photograph and send it across in the various groups. Please show us your videos. And Dr. Anupama, over to you for vote of thanks. We can't hear you, Dr. Anupama. Are you
Okay.
speaking already?
Oh, I'm muted.
Yes, you are.
Yeah.
Sorry. Ashima, I can't see you. I can see everyone. Oh, yes. Okay. Yes. The brightest has been
Please show
on.
us your videos, everybody. And Dr. Anupama, please go ahead.
So, respected Professor Pankaj Talwar sir, who's the president of IFS, Professor Shweta Mittal ma'am, Secretary General IFS, for being our guiding light, our esteemed dignitaries who have enlightened us with their knowledge, dear delegates who have joined us this evening for IFS SIG Counselling and Psychological Support webinar. I deem it a great honor to propose this vote of thanks to all those who have contributed to the success of this webinar. We thank you, Dr. Poonam Nair, ma'am, for your constant support and for, being a motherly figure at every step. We can easily approach you, and you really guided us through this webinar, and we are really grateful to you. I thank Dr. Karen Jensen for her enlightening talk on psychosocial care during RIF, and thank you for being there. We had a recorded version, but having you online with us this evening is really an honor. I'd like to thank Dr. Poonam Nair and Dr. Ashima for conducting a wonderful panel discussion and enlightening us in the dilemmas of counseling in couples suffering from RIF. I would like to thank our knowledgeable panelists for their academic contribution this evening. And last but not the least, thank you, Dr. Ashima and Dr. Archika, for that brilliant role play. You've always been very sporting and spontaneous, and I wish I was there too, but there were so many issues, going on that I was traveling so much that I could not. A big thank you to all our delegates for having spared their valuable time to attend this webinar, and a special thanks to Shivam and Himanshu for supporting this webinar this evening. I'd like to thank my seniors and, to sum it up in Dr. Amita Puri's words, we win when the team wins. Thank you all. Have a great evening. Thank you,
Thank
Dr.
you very much.
Special
Thank
thanks
you very
to you.
much.
Thank you.
Bye-bye.
Bye.
Thank you.
Presentation part.
Yeah, bye-bye. Thank you.
Bye.
Rest.
Thank you.
Bye-bye.
Stop the